Kita masukin.
Ya, pindah-pindahin aja lagi, Sob.
Dipindahin. Ada. To our dear participants, the opening ceremony will begin soon. We request all of you to keep your microphone on mute during the lecture. Please be ready. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And good morning, ladies and gentlemen. Welcome to the online visiting lecture today. First, let me introduce myself. My name is Dwi Putri Wulansari. I will be responsible for hosting this event today. And I'm very glad to welcome Professor Gang Li from Department of Oral and Maxillofacial Radiology, Peking University School and Hospital of Stomatology, as our presenter today. Good morning, Professor.
Good morning, all. Very nice to meet you online.
Nice to meet you too. The Honorable, the Dean and Vice Dean of Faculty of Dentistry, Universitas Padjadjaran, the Head of Study Program Dentomaxillofacial Radiology, Universitas Padjadjaran, and all the lecture staff and the residency students from all majors in Faculty of Dentistry, Universitas Padjadjaran, and all the participants. Ladies and gentlemen, now I would like to inform you about our rundown today. The first session is words from Head of Study Program Dentomaxillofacial Radiology. The second session will be the welcome speech and opening from Dean of Faculty of Dentistry, Universitas Padjadjaran. The third session is lecture presentation from Professor Lee and will be followed by Q&A session. And the last session will be the certificate submission, photo session, and closing. Ladies and gentlemen, before we start our event today, let us pray according to our beliefs for the event to be successful. Let's pray. Next agenda is the words from Head of Study Program Dentomaxillofacial Radiology, Universitas Padjadjaran, Dr. Azhari, Ph.D., Specialist Consultant of Dentomaxillofacial Radiology. Dr. Azhari, time is yours.
Oke. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. The Honorable our visiting Professor Prof. Gang Li from Peking University, the Honorable the Dean, Vice Dean of Faculty of Dentistry, Universitas Padjadjaran, the Honorable all the lecture staff and all the participants. All praise to Allah for this guidance and bless today. Prayer and peace be upon our Prophet Muhammad Sallallahu Alaihi Wasallam. Ladies and gentlemen, Universitas Padjadjaran is currently pursuing a number of goals in order to become a world-class university. This is the reason why we need to improve the quality of learning and research in higher education, and also to develop the capacity, the competence in the global higher education through the acquisition and creation of advanced knowledge. One of strategic approach for developing in goal has an international reputation for its teaching and learning process. Visiting lecture would improve the quality of the teaching process and contribute to providing an international additional perspective for students and development of education and research. The audience for this visiting lecture is teaching staff and resident students. I hope that the presence will be well accepted because it's directly relevant to our area of expertise. I would like to take this opportunity to thank for chairperson, committee members, and speaker, Prof. Gangli, for taking time out of their busy agendas to actively participate in this event. And thanks you to Vice Dean of Faculty of Dentistry, Universitas Padjadjaran, who have granted the committee an honor for setting and conducting this visiting lecture. I sincerely hope you will enjoy the lecture. Thank you very much for your attending. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Ashari. Now we move to the next agenda, the welcome speech and opening from the Vice Dean on behalf of the Dean of Faculty of Dentistry, Universitas Padjadjaran, Dr. Sri Susilawati, Magister Public Health, Ph.D. Dr. Susi, time is yours.
Yeah, thank you, Dr. Dwi Putri Wulansari. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning to everyone. On behalf of the Dean, I cordially welcome to Professor Gangli, DDS Ph.D. from Peking University, Hospital of Stomatology. Thank you for your time for us and fulfill our invitation. I also thank to the head of study program of Dentomaxillofacial Radiology specialist, Dr. Ashari, all of the senior lecturers. I also saw Dr. Ria, Dr. Fahmi, and also our guest from Professor Eharenwi, and all of the participants, senior lecturers, for being here with us today. We are very pleased to welcome those of you who have been with us for a visiting lecture in this morning. As we know that now our faculty is trying to improve the international rank, and visiting lecture program is one of that activities. Therefore, I would like to express my sincere appreciation to the committee and also all of the students in residential specialist program who help us to make this event come together to become a success. At the end, allow me to open this event, and I hope this visiting lecture program will be useful for us, and hopefully all of us can enjoy this meeting. Billahi taufiq wa hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Dwi.
Thank you very much, Dr. Susi. And now we move to the lecture session that will be guided by Dr. Lusi Epsilawati as moderator. Dr. Lusi Epsilawati is permanent lecturer in Dentomaxillofacial Department, Faculty of Dentistry, Universitas Padjadjaran since 2006. and now she's still pursuing doctoral degree at Faculty of Medicine, Universitas Padjadjaran. For academic publication, Dr. Lusi always publishes scientific articles continuously in online scientific journal and also in numerous scientific meetings. The latest articles of Dr. Lusi are analysis of marmica dependence in bone healing process to improve the quality of life, which is published in 2019 in IOP conference series. Second is radiograph analysis of endoperioration in periapical that had been published in 2019 in Journal Radiology Dentomaxillofacial Indonesia JRDI, the online journal of oral and maxillofacial radiology department in Universitas Padjadjaran. And the third is radiographic features of malignant lesion in maxillofacial that have been published in 2018 in Makassar Dental Journal. Well, Dr. Lusi, we will have 60 minutes for the presentation of Professor Lee and also 60 minutes for discussion session. For all the participants, you can put your question in the chat window, or if you want to deliver your question directly, you just can click the raise hand button once the discussion session is opened by our moderator. Please keep your microphone on mute while the presentations. Dr. Lusi, I leave the session to you. Thank you.
Thank you, Putri. Good morning, audience. Thank you for your coming and enjoy this lecture. And good morning to you, and thank you for Professor Gangli. How are you, Professor? Good morning.
Good morning. Good morning.
Nice to meet you.
Glad to meet you here. Yeah.
Yeah. Nice to meet you, and thank you for our invitation. Now, before we start, let me introduce our lecture. Name is Professor Gangli. Professor Dr. Gangli DDS Ph.D. from Beijing Medical University, Department of Oral and Maxillofacial Radiology, Peking University School and Hospital of Stomatology. Professor Gangli in 1993 obtained in his DDS degree and worked at General Dentist more than 6 years. And 1999, Professor Gangli go to Stockholm, Sweden to study. 2004, Professor Gangli got PhD degree in Karolinska Institute. I'm sorry if I got spelled wrong. In 2006, worked at ACTA Amsterdam at Netherlands, and 2011, Professor Gangli served as associated editor from the Journal of Maxillofacial Radiology in Official Journal of International Association of Dentomaxillofacial Radiology, EID MFR. Professor Gangli is currently one of member of Standing Committee and Secretary of two Chinese Society of Oral Maxillofacial Radiology, founder member of Europe Academy of Dentomaxillofacial Radiology, and fellow of International College of Dentists. Professor Gangli has authored more than 80 peer-reviewed articles and been an editorial board member of 7 international peer-reviewed journals. So maybe we start, Professor Gangli, and this stage is for you. Thank you, Professor.
Okay, thank you very much for your kind introduction. It's my great pleasure and honor to be here to give a lecture online. Although we cannot meet each other in person, but I think this also can change our studies. Here. So is that okay? Can you see?
It's okay,
Can you
Professor.
see?
Yeah, okay.
Yeah.
It's okay. So
yes,
we have
yes.
shared the screen. Okay.
Yeah,
So,
thank you, Prof.
So now I will start my lecture. The lecture title is a basic principle on image interpretation to differentiate benign conditions from malignancies. Actually, this is a title given by Lusi. So I have to use this title, and I hope my lecture will be not let you disappointed. I hope this good interpretation. So this lecture will include the two parts. Actually, the one part, the first part is on the basic principles for image interpretation. That means how can we interpret images in a logical way. And the second part is the clinical cases for the interpretation. Just let us practice how to use the law of the interpretation for the image analysis. The most important part of for the image interpretation is actually includes two sections. The one part is about image quality. The other part is about image analysis. When we get the image for analyze, first step we have to do is to judge if the image quality is good enough to make a diagnosis. If the image cannot provide sufficient information, then we have to make a new one. Actually, this image quality mainly related to the projection of the radiographs. That is a technical part from us. That means how to project and expose the image. This mainly related to the exposure parameters that we used for expose the images and the patient position, and if the area of interest will be put in the center of the image actual. So this is only for the technical part, but also is most important for us to decide if the image quality is good enough to make a diagnosis. The other part is the image analysis, is closely related to interpretation, how the radiographs can give us some information about diagnosis. That mainly relating to the knowledge bank in our mind to narrow the diagnosis tree to get a correct diagnosis for certain diseases. So that is part, actually a serial part. That is what we learned from a textbook or what we learned in class from our teachers. So this part is about the knowledge about the certain lesions, about the image features of the lesions. This is one bi-twin radiographs. We know these radiographs we have often used to observe the interproximal caries in the tooth crowns in both jaws. And then we can use this image to observe the available bone heat to see if they have some bone loss from both jaws. So in the images, we have to get the tooth crowns and the available precise crest in one image. So if we take the image like this bi-twin image, we can see the interproximal surface was heavily overlapped. And also the available crest was not in the image, the upper jaw is not image. So by this image, it cannot use it for the purpose to see the interproximal carriers. We cannot use this to observe if there is a bone loss in the upper jaw. So this is not correctly exposed image. So we have to make a new one. Here is the paralytical radiographs. We can see in the paralytical radiographs, we can see the full tooth, the image of the full tooth, and also we can use it to see the lamina due, the periodontal ligament space, and other trabecular bone. And also the image is required to be imaged beneath 2 millimeters of the apex. So we can see the bone conditions just below the root apex. So we can decide if there's a paralytical lesion or not here. So for this correctly exposed paralytic radiographs, we can get all the information about the tooth, about the condition of the bone, around the root apex. If we took an image like this, we can see the root tip was lost and the root here was overlapped. So we cannot get information about root apex if there is parapical lesion or not here. But here is appropriate exposed, and also the root crown and the ratio is not in appropriate ratio. So if we use the image to match the root canal length, it will not give a correct length number. But here, you can see the image is also distorted. So we cannot use this kind of image for the diagnosis. Also here, the parapical area is lost. And also this image gives us a very poor contrast. We cannot get any information. This is actually an underexposed image. For these images, we cannot use it for the diagnosis. So when we want to get a diagnosis, the first step, we have to get a good quality image. So we should make a judgment if the images that we got is good enough and can provide sufficient information for us to make a diagnosis. The same to the panoramic radiographs. Panoramic radiographs can give us the images of both jaws and the teeth. From one images, we can see the bone conditions in maxilla, in mandible, and also the teeth, alveolar bone crest. However, if we put the patient, the chin upwards, we can get the image of hard plate overlapped on the apex of the roots. So we cannot use the image to observe if there's a lesion or something around this apex of upper teeth. Similar, if we make the chin downwards, and then we make the spine will overlap on the ramus, and also you can see the teeth is heavily distorted. We cannot see the bone structures and cannot see the root canals and crown, etc. And also for this image, the chin was cut off. So these images cannot give us enough information for diagnosis too. Also for this one, I think everybody knows that this is a spine shadow that is overlapped in the anterior part of the teeth. So we cannot use this image to see if there is something happened in the anterior part of the maxilla and the mandible. So this is also a good image for us for diagnosis. Movement is also a serious problem for us. So please look at these images. This is a panoramic radiograph from a 7-year-old boy. And then when I firstly look at these images, what impression give to you? Is there deformity in the right part of the mandibular, right? But if you closely look at the images, you can see the tooth in the left part of the mandible is heavily enlarged when you compare with the teeth in the left part of the mandible. And also you can see the inferior border of the mandible becomes curved. And also here, the ramus is enlarged. So what happened? Fortunately, we have taken the patient for a CBCT scan, and we use the panoramic view, a curved function, to create a new panoramic view of the patient. We can see both part of the mandible is symmetrical. So this is the one is a normal person. But this one, why to get these images? Because the patient moved when the machine rotated around his head, and so make the images so curved and distorted. Also, here is another case for the patient. You can see when we look at these images, first impression that there's deformity in the superior part of the mandible. You can see the chin becomes enlarged, And also closely see, you can see the teeth is also enlarged. So that is also because of a movement, because the patient is too big. And then when the machine around him, the head, the patient have to move his shoulder to guide the machine pass through his shoulder. So that small movement make the image looks like that. So if we don't know what happened to the patient, what happened to the process of taking such panoramic radiographs, we cannot judge that this image is not correctly exposed, and maybe we can get a wrong diagnosis from such kind of images. So firstly, we have to decide if the images is good enough, or if the image can provide enough information for us to get a correct diagnosis. Then we come to the image analysis. You can see here is the parapolitical radiographs. From these parapolitical radiographs, we can see clearly about the tooth crowns and the roots, and also the lamina due, the periodontal ligament. And also we can see the trabecular bone in a normal pattern. However, when you look at these images, what we can see from these images, is there some abnormal thing here? Yes. If we look at the trabecular bone just between the laser incisor and the canal, and then we can see the trabecular bone becomes orange peel appearance. Here is a normal appearance of the trabecular bone, but here becomes an orange peel appearance. So what is happened here might be something. In this case, this is fibrous dysplasia. Also another case showing the similar thing. Let us to be carefully observed images. From these panoramic images, we can see there's the bone density around the teeth here, the two group of teeth here becomes darkened. And also, if we look at closely, we can see that the laminar dune becomes wider, and also the periodontal spacements, the laminar dune, actually it is a little bit destroyed. I cannot see it clearly. From these images, we can see here, there is the periodontal ligament space becomes wider, but here in the lower part of the tooth, we can see there is a destruction of the bone, and also the laminar dune is not clearly shown. You can see here the laminar dune is very clear along the second premolars, but here for the first premolars, in the the lower third part of the roots, the laminar dune becomes unclear. So what happens to this leaf? So in this case is the malignant lymphoma. So these cases showed us that when we analyze the images, we have to be careful and to carefully analyze every part of the images. The same also to the panoramic radiographs. This is optimally exposed panoramic radiographs. Contrast to the intraoral radiographs, we can get more information from panoramic radiographs because they have both jaws imaged on one images. So we have to analyze this information, these structures in a systematic way, so that we cannot neglect any useful information that we can get from the images. So when we start to analyze a panoramic radiograph, we have to think a method that is very useful for our own to analyze the image. In this case, I would recommend you to analyze the images first from the left, the right part of the maxilla. The right maxilla, first to start here to see how the bone forms and goes left to the left maxilla, and to the mandible, to the condyle, along the condyle to the ramus, and to the left mandible, to the left, to the right mandible, to the condyle, and come back to the left-right maxilla. First, we analyze the bone tissues, and then we come to the teeth. From the teeth, from the right maxilla, to carefully to see each teeth in the jaws and the lower jaw of the teeth. And then we analyzed alveolar crest to see alveolar bone in both jaws. In such a way, we cannot neglect any useful information. Here is the anatomical landmarks in the panoramic radiographs. So from panoramic radiographs, sometimes we have to make our attention to some specific anatomical structures. For example, we have to carefully look at the pterygoid mandibular fossa here, because in some cases, lesions can develop just along the nerves here to make these fossas widen. And then we have to look carefully about the mandibular canals, because some lesions can make the mandibular canal becomes wider. So if the mandibular canal becomes abnormally widened, so maybe the lesion comes from the vascular or neurous region. And then we have to make our recognition about this posterior wall of maxilla sinus here, because sometimes people often mix it with the posterior wall of the maxillary process of the zygomatic process of maxilla. So sometimes mix this as a posterior wall of the maxilla sinus. So for this normal landmark, they have to be bear in mind, and they can recognize them well and clearly. And also I have to mention this part. This part is the inferior border superimposed here from the opposite side. So this one is not a normal image, just one blurred image from the opposite mandible. Then we come to how to interpret the image. In these panograms, we can see a lesion in the anterior part of the mandible. And then the question is how to describe such a lesion. Usually we use the law of Laupes. Law represents location. P, the letter P represents peripheral. The letter E represents the internal structure of the lesion. And the S is the surroundings of the lesion. So how the surroundings anatomical structures happen when the lesion grows up. For the location, we have to see clearly what is the position. That means where the lesion located. Is lesion a single or multifocal lesions? And also the size, how big of the lesions. Here is some examples. You can see here, this is the over radiolucent single lesion just lies in the mandibular angle. This lesion is below of the mandibular canal. And also from here, you can see a lesion is a multifocal lesion in the mandible, anterior mandible, and extended to the right body of the mandible. The location of the lesion sometimes can give us some hint about the nature of the lesions. For example, here, the lesion is just beneath of the mandibular canal. So this lesion cannot be a odontogenic original. Most probably from the bone, from the osteo origin. In this case, it's maybe a Staphylococcus cavity, but because it's just beneath of the mandibular canal, so it is impossible to be a odontogenic original. P, periphery, is also refers to border. That means if the border is well-defined or ill-defined, this is important for us to decide this lesion is a benign lesion or a malignant lesion. Here is show some examples here. Here is the well-defined border of lesions. The border is very clear. Sometimes if the lesion is small within the bone, so you can just see it like a oval-shaped or round-shaped lesion. But if the lesion becomes big and growing up, it may expand and make the surrounding teeth being displaced. So here you can see the molar is being placed, and also in the anterior of the maxilla, you can see the scissors was displaced. But if the lesion expand outerly, so the bone will become expanded and make the cortex, the bone, become thin. The cortex, if the cortex want to be integrity, so the periosteal bone will be layered on the cortex to make it continuously integrated. So for this kind of lesion, this is a benign lesion. So we cannot see any bone structures, and also the nature of the benign lesion is just for the occupant. So it gives a behavior of expansion. But for benign lesion, actually, the keyword is expansion. But for malignant lesion, it's not the same. You can see here, the bone is destructed, and also the border is ill-defined. You cannot see clearly the border because the lesion infiltrated into the surrounding tissues. And also here, there is soft tissue within the maxillary entrance, and also this tissue makes the maxillary lower border becomes destructed and also entreated into the available bone. And also this lesion makes periodontal ligament space wider, and also the bone here becomes dense, and also we cannot see clearly where the lesion is. And also here shows the multiple lesions underneath of the roots, the root roots. And also here is a lesion within the papilla and makes the germ of tooth upwards movement. And also the cortex, the border of this germ is ill-defined, and I cannot see the border of it. That means it has already been destroyed. There's other four types of the bone destruction that's usually arisen from the osteosarcomas. So you can see here that is the bone, the cortical bone and the trabecular bone is destructed without osteo reaction. But here you can see the bone is stimulated with the new layer of the bone formation, but the newly formed bone and the cortex of bone was also destructed at the same time. And this is the bone destructed, showing that the Periosteal was reacted to the stimulation and makes a new bone formed here to make them look like angle. So this is so-called Codman angle. And most often we can see the new bone formation like this, like a sunshine, a sun-rays appearance in the radiographs. So they say sometimes if we get this kind of image information, we can think this most probably the osteosarcoma. And also another kind of bone destruction is the totally resorption of the bone, makes the teeth inside the bone looks like floating in the place. There's no bone there anymore. So totally destroyed. So we can now see a clear border of the lesions. So these ill-defined borders of periphery give us an information of a malignant lesion. Now comes the internal structures. The internal structures usually have three types. One type is totally radiolucent, just like cyst. There's no radiopaque inside, totally radiolucent. Another is the totally radiopaque, just like odontoma, and also like this osteosis here. And another internal structure is a mixed density, means that within the radiolucent backdrops, there are some radiopaques inside of the radiolucent backdrops. So that it kind of is a mixed density. So the internal structures can also give us some hints or information about the nature of the lesions. So if we know about, can make sure that the internal structure is totally radiolucent or totally radiopaque, we can much narrow our diagnostic tree to a certain diseases. And then the surroundings. Surroundings is mainly used to analyze the effects of the lesion on surrounding structures. The surrounding structures include teeth, lamina due, periodontal membrane space, inferior alveolar nerve canal, that the mandibular canal, the mental foramen, also the maxillary antrum, the surrounding bone density, and the trabecular pattern. Also the outer cortical bone and the periosteal reactions. Here is one case that we used for the law of piece analysis. This case is a male, 13 years old boy. His complaint is 2 months ago, he found mice in the anterior mandible. The mice began with a fingernail size and quickly grew up to a size like plump. No pain and no numbness. The clinical examination shows that a semi-rounded mice in the anterior region of the mandible. It is 2.5 centimeter in diameter. When you palpate, the border is smooth and clear. It's not movement, no hardness. It's very hard. It's very hard, but there's no pain. You palpate it. Here is the radiograph of this patient. So we can see there is the round with the anterior part of the mandible. So what about the law of Laupes? The location, we can use it as location where it is the round-shaped single lesion in the anterior region of the mandible. The size of the lesion is between the tooth 44 to the tooth 33. Periphery. Is it well-defined border? Yes, the border is well-defined and clear. What about internal? Is there something internal side? Yes, we can see that the tooth 42 is within the lesion. If we closely look at the lesion, maybe we found some radiopaque dots within the lesion here, but because of the ghost image of the span overlapped in this area, we cannot make sure that is the true. So just make doubt if there is some radiopaques in here. And if we look at surroundings, we can see that the 4-3 impacted and displayed laterally. And also the teeth 4-1, 3-1, and 3-2 is displayed. The tooth A3 and 2 stay in position. But for the root of the teeth, we cannot see any resorption. So when we take a CT scan, that shows an axial view of CT scan, we can see there are many radiopaque dots circled within the lesion, just along the border of the lesion. And here is the impacted tooth. From this information, what can we get? How to analyze the images to guide a diagnosis? So comes the next part is to interpret the findings. When we make such analysis, we have to ask ourselves, is this a normal variation or it is abnormal? Apparently, this is abnormal lesions. And we ask ourselves, is this a developmental abnormality or it is an acquired abnormalities? Apparently, this is acquired abnormalities. And then we come to ask us, is it a cyst? Is a benign neoplasm? It is a malignant neoplasm or inflammatory lesions. The other part we have to ask us, is a bone dysplasia or the lesion from vascular or neural origin? Or it is a metabolic disease? Is it trauma? Apparently, after we look at these lesions, you can see it is well-defined borders. And also there's one tooth within the lesion. If we look at the CT examinations, yes, we can see circled radiopaque dots here. So all this means what can give us, yes, it is cannot be a cyst. From this image, we can see maybe it is a cyst or maybe something others. So after looking at these images, we can make sure that it is not a cyst, because a cyst often gives a totally radiolucent appearance inside of the lesion. So this makes us that this must be some benign neoplasm in the anterior mandible. But what kind of lesions it is? So in our knowledge bank, we know that there are some lesions give such a radiographic appearance that within the radiolucent backdrops, there's some radiopaque inside it. What is that? This circled radiopaque dots is very specific and usually is for the lesions of adenotoid autogenic tumor. But for other two lesions, we can also not rule out because it also gave the radiopaque dots or radiopaque things within the radiolucent backdrops, but in a different appearance. So these two lesions is calcifying epithelial autogenic tumor and calcifying cystic odontogenic tumor. So from these cases, they finally give the diagnosis that this, the benign Lesion neoplasm in the anterior mandible. The most probably, the first preferably diagnosis is adenomatoid odontogenic tumor. The second possibility is calcifying epithelial odontogenic tumor. The third is calcifying cystic odontogenic tumor. After excision, the pathological examination shows us, here is the radiographs, here is the images from the histological examination. Give us the final diagnosis is adenomatoid odontogenic tumor. So from this way, we can now narrow our diagnostic tree and make a correct diagnosis. Here is the one panoramic radiograph taken 4 years after the surgery. We can see here the surgery area becomes well cured, the bone healing very well here. So this also suggests this is a benign tumors. So now we come to the next, that is for the clinical cases, the interpretation. The first case is a female. She is 13 years old when she came to a hospital for taking these radiographs. In these panoramic radiographs, we can see it's a radiopaque mice in the left mandible. So when we use the law of Lopez to describe the lesion, we can see that where the lesion located, it is in the left posterior border, posterior mandible. And what about periphery? Yes, it is well defined. And also we can see a radiolucent capsule around the radiopaques. And also we can see a teeth was impacted just underneath the radiopaque mice. And also the radiopaque mice is totally radiopaque. We can see the teeth 3, 6 was impacted underneath of the mice. We can now see the 3, 7. So what is this? I think most of you have already known that this is odontoma. I think most of cases we cannot directly diagnose with only radiographs, but for odontoma, in my opinion, it is the only few lesions that we can use it for a direct diagnosis. So when we see a radiographic appearance like this, we are very sure that this is odontoma. So for such few lesions, we have to bear in mind that what is their radiographic appearance. So this is the odontoma, very typical. The second case is from 16 years ago. She came to a hospital for the orthodontic treatment. And then the dentist asked her to take the cephalometric radiographs and the panoramic radiographs. So from the panoramic radiographs, they found there is a cystic lesion in the mandible. And then they introduced the girl to our surgeons. In the clinical examination, they found that the 4 second molars have already completely erupted. And the lateral incisor in the right lower jaw is movable. And the gingival buccal sulcus was swelling, and on palpation, the swelling feel crepitation. Results of blood and serum chemistry analysis were within the normal ranges. Here we can see the face image of this patient. The mandible is asymmetry. If we open the mouth, there ain't no any limitations. It's just in the normal range open. We look at in the right angle, we can see that the mandible is swelling here in the right part of the face here. And also we can now see the here in the left part, we can see the mandible border. But here we cannot see the mandible border. If we look at intraorally, you can see that is the gingival buccal sulcus swelling. Here is swelling, but if you look at this part, this is normal, just very normal. So there's no swelling here. If we look at the panoramic radiographs, and there is the big lesion within the mandible. This lesion is multifocal. You can see there are septas within the lesion. And also you can see inferior border becomes thin. There is no root resorption within the lesions. And also the lesion is totally radiolucent. If you look at it carefully, you can see the lesions also moved upwards here, so make the alveolar crest upwardly moved or expanded. Look at carefully here. Maybe you can get some radiopaque things here, but not unsure. So what lesion of this? Then we also take the CT images, that is axial view. Here is the soft tissue window. We can see there is a lesion here and a septa within the lesion. The lesion expands to the left mandible, and also we can see expanded laterally, buccally, and lingually. And also the cortex becomes thin. Here is the coronal view of the CT images. So we can see the lesion, the thin, we can see the septa. This is not radiopaque things, it's just the septa of the lesions. There is the expansion of the bone, the cortex becomes thin. What is this? What can get a radiographic diagnosis from these images? Because it's have well-defined borders, so we can think it is a benign nucleus in the mandible. And then, what is that? It is the mandibular cyst or the mandibular cyst-like lesions. When we got the surgery, that is what we have seen during the surgery. We can see the lesion is a cavity and filled with blood. So from this, we know that this is not a cyst, because cyst is not full of blood, and also they have the borders. The cyst should have the epithelial borders around the cyst. So there is empty, there's nothing here, only fulfilled with the blood. It's a cavity. What lesions can make such appearance? So it comes to the simple bone cyst, and most probably a simple bone cyst. So when they make the pathological examinations, it shows us that, yes, it is the simple bone cyst. So the third case is from a 14-year-old male. He found a hard mice in the left submandible just by chance 2 months ago. The mice gradually grew up. There's no pain, no numbness of the lip. When we make a clinical examination, we found that the border of the mice is well defined, but it's very hard. The mice is about 3.0 multiplied 1.0 centimeter. Is unmovable, no tenderness. The mouth opening was normal. The gingival buccal sulcus was normal. Results of blood and serum chemistry analysis were within the normal ranges. Just before our image analysis, what can we get from these informations? I think a benign nucleus or benign lesion is the first impression to me. Then we will look at the images. It makes me, at that time, a little bit confused. You can see there is a lesion within the left mandibular angle. This lesion in the central part is radiolucent, but also you can see the destruction of bone around lesion and also make new bones seams here. And also we can see the second mole, the German center, will also moved upwards. So what kind of lesion should be this? There is destruction of the bone, and also there's new bone formed. We took a CT image. This is the plain CT images. These two are the enhanced CT images. This is soft tissue window, and this is the bone tissue windows. You can see that in soft tissue window, there is a big mass of soft tissue lesions within the parapharyngeal area, and also submandible regions here. And in the bone region, we can see the destructed bone. There's open here. The legal side of the ramus has already been destroyed and makes it open to the lesions. When we make the enhancement of the CT images, we found that a slightly enhanced border of the lesion. At least the lesion has a very clear border, but inside without any enhancement. And also we can see the lesions within the bone is also not enhanced. So the soft tissue lesion is connected to the lesion from the bone. They are actually the same lesion. So now it makes us confused. Is this a lesion comes from the bone or lesion from the soft tissues invasive into the bone? And then we make the ultrasound examination. It shows that the lesion originally is from the bone, not from the salivary gland or soft tissues. And then make us another thinking. Where is lesion comes? You can see here is also the coronal view of the lesion. And here is coronal view of the lesion as the bone structured, and the lesion gives well-defined borders. Also give the behavior of expansion. Also here, you can see the bone destructed here, and here is the enhanced images. And then we don't know if the lesions comes locally all the lesion comes from the distant part of the body. That means if this is a metastatic lesions from other part of the body. So here shows the 3D CT images. We can see the bone destruction, and also we can see the vessels, rich vessels here. And then following the discussion of the metastatic lesions, the possibility we made the PET-CT to see if the lesion comes from the other part of the body, if it is the metastatic lesion. We found that lesion only located in the mandible and also surrounding tissues, here plus pharyngeal area, and out here infratemporal fossa, the area here. It's not from the other part of the body. So this is localized lesion. And then what radiographic diagnosis can we get from these images? Yes, because it gives a behavior of well-defined borders. Although it has some bone destructions, and also the border of the bone destructed bone is very clear. So first thing we think it should be benign neoplasm in the mandible. After we made the surgery and excises these lesions, we can see the specimen is a solid state of the lesions. And also we can see the bone destruction. Here, that is the legal side of the mandible. After histopatological examination, autogenic myxoma was made. That is the diagnosis from histopatological examination. But there are some active growth cells. That means, yes, it is a benign tumor. It is autogenic myxoma, but in some part, the cells grows very actively. That means there's a prone to a malignant lesion. So we should be very careful about this kind of lesions. This case we have already reported in DMFR. So if you are interested in this and want to look for more information, you can check the literature. The last case that we will present today is a male. He's 26 years old. A swelling in the left lower jaw was managed with curettage 4 years ago. The pathological examination revealed ameloblastoma. 2 years ago, the swelling was recurrent and expanded. Reoperated with curettage in the local hospital. 1 month ago, the left lower jaw was swelling with dull pain, numbness of the lower lip. When we make clinical examinations, we found that the face was symmetric. The maximum mouth opening was 40 millimeter, no deviation. That is in the normal range. Teeth 4.7 to 3.5 lost. The mucosa overlying on the alveolar process was normal. The bulge of the left lower jaw on both buccal and lingual sides, and always pain and pucky when palpating. The size of the left lower lip was decreased. So from the description of these examinations, what the first impression in your mind is a benign things or malignancies. So when we look at the images, the panoramic images of the patient, we can see actually there are 2 lesions in the mandible. One is just before the mandibular angles, the right mandibular angle, and another one is at the anterior region. The lesion in the mandibular angle is well defined, the border is well defined, and also totally radiolucent. If we look at the lesion in the anterior part, actually you cannot see the clear border. You can see here is not clear border. Also, the lesions invasive into other parts. Here is also the lesions. Also, we can see some lesions here. So this is the lesions in the anterior part of the mandible. When we take CT images, that is axial CT images, we can see their lesions in the anterior mandible, and also there is a well-defined bordered lesions here, round shaped. You can see the bone destructed, and here the lesion in the mandibular angle is round shaped. Here shows the coronal view of the CT images. We can see the well-defined border of the mandibular angle of the lesions here, but in anterior part, the lesion, the bone has been destructed. So from these images, what radiographic diagnosis can we make or can we obtain? First question, I think, is this one lesion because there are two parts in the two parts of the mandible? So the lesion is one lesion or two different lesions at the mandible, different parts of the mandible. So this is the first question. So usually only one lesion occurs in one place, that is in the mandible or in the maxilla, or only one lesion. Rarely to have two lesions together. So, but from behavior of the lesions, from the clinical examinations, also from the reading of our radiographs, they also suggest this may be two different lesions. So it's very difficult for us to make this is one or two. So when we review the radiographs, we found that this one is well defined. The border is well defined and also have the behavioral expansion. But for this one, the border is ill-defined. Seems like it's just a destruction of the teeth. So we made a decision that the angle, the lesion in the angle, mandibular angle, is a benign neoplasm. In the anterior part is a malignant lesion. And then after surgery, we got pathological examination. We can see that the lesion in the chin is also sarcoma, prone to malignant change in ameloblastic fibroma, because you see that the patient has got several surgery for osteoblastoma. So that may be a malignant change from ameloblastofibroma. And then the lesion in the left mandible is ameloblastic fibroma. So actually, this also from the same lesions. It are same lesions, but the one in the anterior part of the mandible is malignant changed, becomes also sarcoma. So that is the final diagnosis of these lesions. And last, I would like to introduce the poem written by Dr. Robert Collins. The name of the poem is Homage to Radiology. In darkened rooms with focused gaze, on borders, shapes, and shades of grace, observant eyes do much discern from images that raise concern. Thus, mysteries in black and white, with thoughtful study, come to light, illuminating the unseen, advising those who intervene. Now, radiology works best with findings clinically assessed, but as a novel thinking support, might ever looking fully SWOT. So this three parts, I think, make a delicious description about what we have done in our daily clinical work. They have to be careful to look at images to differentiate different shapes and shades of grease from it to make a final diagnosis. And also here, I think it's also very useful for us. Certain cysts, it could be rumored, can appear like a bone that's tumored. Naming each a burden carries, since representative treatment varies. So sometimes we cannot differentiate from a tumor. So photons tell a quiet story. Therein lies the Röntgen's glory. Listen with expanded slide to give interpretation flight. The final part, you can see with Hubble periscopicity and endless curiosity from 2 dimensions, sometimes 3, is shaped diagnostic tree. So finally, we have to get useful information from those grid and shades and shapes to make our own diagnostic tree. So I devoted this to you, our radiologists, so we can all make our own diagnostic tree in our daily work. Thank you very much for your all.
Thank you, Professor Lee. Thank you for the presentation. It's very good. We got a lot of information. It's very nice, Professor. Thank you very much. Now we come to discussion. So the audience maybe is some question. We start the discussion session. Maybe Dr. Fahmi. Thank you very much, Dr. Fahmi. Dr. Fahmi raised a hand. So maybe Dr. Fahmi can ask the question directly. Thank you.
Thank you very much, Professor Gangli, and excellent presentation for you. I have a question for you about talking about the quality of radiographs, the extent to which we can change the resolution, contrast, brightness of digital radiograph. Based on your experience, is there a gold standard for the resolution, contrast, and brightness of these radiographs? Is it possible to change that? Thank you.
Yeah, that depends on what technique you used. For the film radiographs, you cannot change the resolution of the images. It's just because of you take it at once and then make the images already fixed on the film. So you cannot change any resolution of it. That resolution depends on what kind of film you use. For example, if you use the E-speed intraoral films, or you use the D-speed film, or you use the F-speed film, this gives the different resolution of the images. And if you use the D-speed film, and then the resolution will be high, but also will be required more exposure to the patient. If you use the F-speed film, the exposure will be low, will be only, I think, 1/10 of exposure to the D-speed film, but also give a similar image quality with respect to in terms of resolution. So we have done some studies on it. I found that the resolution of the image from the f-speed film is comparable to those from the D-speed film. With respect to the digital radiographs, you have to change the resolution by yourself. Sometimes if you use the phosphoplate, and then you can change it from 10 lamperes millimeter to 20 lamperes millimeter. You can change it yourself, but finally you have to get more exposure to patient. I think what resolution you select, that depends on the task, what you task you need to use to diagnose this. So that depends on you, but most probably you can use a fixed resolution when you take a digital radiographs. And also we made some studies on it, because when you think of resolution, and it's totally different from company to companies, from the products to products. And some products maybe give you high, for example, the Degora Optime can give you 3 spatial resolution for selected 8 lampere millimeter and 12.5 lampere millimeter and something like that. But if you from the another, for Scanora or another company's products, maybe that it gives you the lampere millimeter, maybe 10 lamperes millimeter and also 20 lampere millimeters. It seems very high resolution, but actually when you make studies on it, and you will find that the real spatial resolution is not connected to the theoretical calculated resolution. That means you calculate it from pixel size. So you have to make your own study on the, or you have to refer to the articles or studies regarding the spatial resolution to make your own, if that is the resolution that is useful for your clinical work. So that is important, I think. So you have to balance, when you think of the spatial resolution, you have to balance the exposure to the patient and the image quality, if that is good enough for your diagnostic purpose.
Okay, thank you for your explanation. Thank you, Professor.
Oh,
Thank you, Professor. We have a question from chat. Is from Felicia. Thank you, Professor Gangli. Is it possible for malignant lesion of mandibula show benign appears in OPG? As we found 2 cases with only single small to medium size, well-defined, round totally radiolucent, or on periapical without destruction of the surrounding tissue, which turned out to be squamous cell carcinoma of the mandible. Is it understandable? Maybe Felicia, you can directly ask to Professor Gang. Maybe.
If there are some radiographs can share on the screen, maybe it's easier for us to understand the question. Otherwise, just from the description is not so easy to grasp or get the idea about it. I think from my hearing, it's about the border of the lesions or outside the inside the radiopaque things within the lesions, is right?
Yes, maybe. I can understand what is the question. We found 2 cases with only single small, medium-sized, well-defined around. Maybe she asked about something, some lesion in mandible is like normally like well-defined, but maybe she's asked about how to define the squamous cell carcinoma with the border maybe.
Yeah, I think the question maybe is about how to differentiate from malignant additions from benign tumors because sometimes they give a similar behavior. Yes, I agree with that. In all clinics, we always found that it's very difficult sometimes to differentiate the lesions is a benign or is a malignant. But you have to bear in mind that if you get such kind of lesions, you can just make more examination. For example, you can refer the patient to take a CT exams. And then you have to use the enhanced CT examination also to see if there are changes in the inside of the lesions. That means if that is malignant things, there must have some viscerally enriched appearance. So if we enhance these images and enhance the CT image, and you can see more of the enhancement inside the lesion. And also you can see the border if that's clear. And after this, if you cannot get some clue, you can even let the patients refer to MRI examinations to see at different sequences from T1, T2, and other sequences, if there's give some hint about the nature of the lesions. So actually, it's not an easy way or easy thing for us to differentiate the benign tumors from malignant things. So that is why I think today Lusi invited me here. And also I have already told Lusi that before this lecture that also in my clinics, we have to make a diagnosis, not exact diagnosis. If we can make diagnosis of this one is malignant lesion, this one is a benign tumor, is already good, especially for the malignant things. You cannot to give exact diagnosis of what malignant case is that. So if you think more about malignant things, and then most of the malignant lesions is in oral cavity, is from the squamous carcinoma. The nature is squamous carcinoma. It just lies on different parts of soft tissues, like the tongue, the gingiva, or the mouth floor. If we think of the sarcomas, that maybe the osteosarcoma is the most probably things. So when we make such kind of things, we have to make more examinations. So just like the case I showed in the 3 cases, we have already made a PET CT for this case because we suspect it is maybe a metastasis lesion from other part of the body, meaning the breast or prostate cancer. So we made such a decent PET CT examination. So that is all. So I saw the question here.
Yeah, that's enough for me, Professor. This is the next question, maybe. This is the next question is, good morning, Professor Gangli. Thank you for a very nice presentation. I would like to ask some questions. For the first, I would like to ask about the case number 2 of your presentation, which the definitive diagnosis is simple bone kiss. Why don't you add amyloblastoma as your differential diagnosis due to the well-defined multilocular lesion in mandible? Second question is, what if find ill-defined radiolution in maxilla? What we suspect as benign neoplasma rather than malignant, as the first differential diagnosis due to the maxilla bone is more cancerous than in the mandible? It's the very long question. Maybe
okay. I answer the first question. Why don't I add amyloblastoma as the differential diagnosis? I think this is a very good question. Actually, usually the amyloblastoma is the most often happened lesions in the mandible. And also it gives us the appearance of multilocular things. But if you look carefully about the lesion, you will find if it is the ameloblastoma, there we give some scalloped appearance. That means the border is not so smooth. It's made some scalloped. The septa inside is not so straight, should be curved. So that is the reason why we did not add it to the differential diagnosis. I don't know if you agree with that, but if you look carefully about the ameloblastoma, you will find the skin, the inside will be curved and coarse, not like this. This, if you look at it more straight, and also in the border, especially in the inferior borders, the lesions not scalloped, not like the thing from the shell. If you cut in the sand, get a very sharp edge. So this did not give such experience. But I think your suggestion is good. Sometimes we have to think about this. But especially when we go to the surgery and we see it, or the surgeons reported that there is no blood, there is no fluid inside, and also there is no the epithelial borders around the lesions, and then we think the simple bone cyst may be the most possible diagnosis. But as you know, we cannot wait until the surgeons make surgery. So, and then we can expect the diagnosis. So that is just to show here what it looks like in the surgery procedure. So you can give an impression about these kind of lesions. But at least I think a simple bone cyst has some features. That means they sometimes grow just between the teeth, and the lamina do will be infected, but the tooth root will not be observed. So they'll be complete. So that is the kind of tips maybe for this kind of lesions. And also another important feature is that there is no symptoms. The patient usually found it accidentally. That is the incidental findings about make radiographs. So that is also important. And the second question is about if we find ill-defined radiolucent lesions in the maxilla, could we suspect as a benign rather than a malignancy? I think when we use the panoramic radiographs, it's very difficult for us to say it is a well-defined or ill-defined border. Sometimes we can see it, but sometimes because of many anatomic structures overlap together, and you cannot clearly see the borders. So for us, I think for the maxillary lesion, I recommend you to make CT examinations so that you can see clearly about the borders, about the inside of the lesions, what the internal structures, and something like that. So that will help you to make the diagnosis. But for the lesions within the mandible, I think panoramic radiographs really can give us more information, because we have used these images for almost 100 years, and we have got lots of experience of thinking on it. So sometimes I prefer to use first to use panoramic radiographs to get the overview about the lesions, and then it comes to the CT examinations and comes to the enhanced CT examinations, and then if it cannot help us further, and then we make the MRI examinations or even PET CT examinations. That means you can use all the examining methods to rule out all the other diagnoses to narrow your diagnostic tree to make it more specific.
Yeah, thank you, Professor.
That's okay.
Okay, it's very, very good. The next question maybe from Mary. Professor Gangli, thank you for the great presentation. I'd like to ask how to differentiate between benign and malignant lesion occur the maxilla sinus.
This is, I think, is also follows the principle of the law piece. I think usually we have to differentiate the lesions from maxilla bone into the maxillary sinus, or the lesions originated from maxillary sinus. So that is usually we have to think for the first. And second, if all the lesions coming from the maxillary sinus, and then we should be carefully read the image about the wall of the maxillary sinus. That means if the lesion has destroyed the walls of the maxillary sinus, if they destroy the walls and make ill-defined borders, just like the case I showed you in the presentation, and that maybe is the malignant cases. Otherwise, if the border is well-defined, just cyst-like lesions within the maxillary sinus, that should be benign tumors. Sometimes you have to think of the inflammations, because inflammation is very difficult to differentiate from malignant lesions, especially in the maxilla or in the mandibles. So we have to think more about this. But the principle, I think, is the same. If that is ill-defined, if they destroy the border of maxillary sinuses, that should be most probably is the malignant lesions.
Yes, maybe it's so hard to see the border in the sinus, Professor. Is that correct?
From panoramic radiographs, I think it's not so difficult. If you look at the images, if the image, of course, firstly, if the image is taken correctly and is a very optimally exposed images, and then you can see the posterior border, and you can see the inferior border, and you can see inner border of the maxillary sinus. But if you just the lesion within the maxillary sinus, that is difficult for us. So you have to take a CT examination. That will make us see it more clearly.
Okay, thank you, Professor. The next question is from Satyadi. Good morning, Professor. Thank you for the presentation. I would like to ask the difference in the radiographic image of some central vascular malignancies. Can you understand, Prof? Maybe she asks about the. Okay.
I think it's also very, very difficult one. I think it's a soft tissue malignancies. It should be within the soft tissues. It's not in the bone. So sometimes it's quite hard for us. Very hard to differentiate from the benign things. But also you have to closely related to clinical examinations. You have to think more about clinical examinations. And if the clinical examination gives some hints, such like numbness or roughness of the sense, the lips or something like that, or makes you some feelings unsensible, and that may be a case for the cases differentiates. So you have to connect to the clinical examinations. Sometimes if you only depends on the radiographic diagnosis, it's not possible to differentiate the malignant lesions and from the benign neoplasm, especially for those from the soft tissue regions like neural regions.
Okay. Understand. Thank you very much for the answer. Maybe we get the next question is, thank you for this presentation, Professor Gangli. I asked you how to differentiate malignant process in after followed inflammation. So it's not clear malignant pattern. How is the strategy to differentiate?
Yeah,
It's
yes,
very hard.
Yeah, that is a very, very good question. It is often a question that we might in our clinics. Yes, it is very difficult to sometimes to differentiate the inflammation from malignant neoplasm. But if you think in such a way, if this is an inflammatory lesion, and then you can get some information from clinical examination. For example, they have got inflamed before, they can get the right, they can tender, the paste should be right, yes, and that should be, if your puppet will be get is tenderness, and also it's painful. So this kind of inflammatory situation should give you some hints about this lesion. This is not a malignant process, because most of malignant lesions did not give you any painful or expanding swelling appearance or radiographic appearance or clinical examination manifestations. So it's different. You have to closely relate it to the clinical examinations. For example, the fever, the body temperature should become high. That is reaction to the inflammatory. But from the malignancy, the temperature, body temperature should be the normal. So I think you have to connect to the clinical examinations.
Okay, thank you, Professor, for the answer. Maybe we next to the question. Oh, many questions, Prof. Oh yeah. Next question, dear Professor Gangli, I would like to ask: is there any specific radiograph feature for the malignant lesion that arise from benign? Is the radiograph feature more likely to benign lesion or more similar with malignant lesion? Maybe can you understand?
Yeah, I think the last cases I showed you answered partly of your question. Yes, actually, there's no some specific features from malignant lesion arising from benign. From last case, you can see that in anterior part of the lesions also behaviors like malignant lesions. They have ill-bordered and invasive in the into the surrounding tissues and bone tissues. So actually, they gives appearance of the malignancy. So that is why we finally make a malignant lesion in the anterior part. But if you look at the part in the angle, the lesion is just round and give a very good border. So that is the appearance apparently of the benign things. So if you ask me if there's the features that is that we can use to differentiate from the malignancies region from benign tumors, I have to say no. But sometimes you maybe make a diagnosis about the benign tumors, but finally histological examination shows that it is malignant things. Sometimes happens, most probably sometimes. So that's why I think it's very hard for us to make a exact diagnosis. So sometimes if you can make diagnosis that it is benign and it is malignant, it's already okay for us. But for some cases, from my experience, is that if some cases origin from the benign tumors to become a malignancy, and then the borders will become unclear. So sometimes, especially for the keratocyst there's many things, several times, just like ameloblastoma, keratosis cyst, and then maybe the borders after several surgeries will become malignant. So you have to look carefully about this kind of lesions. If the lesions only have one surgery and not recurrent later on, that will be benign. If the lesion recurrent from several times surgeries, lesions, and also at the same places, you will be carefully about it if it has already become malignancy. So that is my experience.
Thank you, Professor. Now the next question. Thank you for your presentation. For the presenter, Professor Gangli, CBCT is much more popular here in dentistry, but I see that you usually use CT. You had a case that had soft tissue involved. Is it something that we have to worry a lot, which makes CT is first choice rather than CBCT for tumor? Or maybe is there some specific case where CT is prepared over CBCT and nice vice versa? Thank you.
That is also a very good question and very practical, because we also have the similar problems because in dentistry, dental clinics, only the CBCT can be used. So most of dental clinics only make CBCT examinations. What I have to say that, yes, for the tumors, I would prefer to use the CT because you don't know if the lesions have invades in the soft tissues. But if you, for most of the cyst lesions, it's only confined within the bone. So I think in these cases, CBCT is already enough for make the examinations. We don't need to go to the CT examinations. But if you have very complicated cases, just like the case that I showed you in the third one, that odontogenemisoma, and then you have to use the CT even more complicated examination methods to make sure your diagnosis. So that depends on the lesions in your hand. That is, if the lesions just confine in the bone, and then CBCT examination is okay. If you see the lesion has invaded the destroy of the bone, and then you have to examine the soft tissue if it had already been in the soft tissues and make soft tissue involved, so that you have to make the CT examinations. That is my answers.
Thank you, Professor. It's a lot of question, Professor. We go to the next question. Dear Professor Lee, thank you for the enlightened presentation. I still curious about the early stage sign of malignancy around the periodontal tissue. Is it alteration of the lamina dura and periodontal membrane could be early sign of malignancy? Is there any sign that have to follow the alteration of the lamina dura and periodontal membrane to consider the early stage of malignancy? Thank you.
Yeah, thank you for the question. Yeah, it's what I show you there, it just want you know that you have to be carefully observe every part of the images. The periodontal membrane space and the lamina dura is a small part in the Paralytical Radiographs. And if we just think, because most of the cases we use it for the caries diagnosis, we use it for the periodontal diseases, and we usually omit many or neglect many other diseases. We have to, firstly, we have to know what is the normal appearance of the lamina dura, and what is the normal appearance of periodontal membrane space. And then what is the normal pattern of trabecular bone. And then we can analyze if there are some changes of these things, especially when these bone structures has been destroyed, or the density of the local bone becomes radiolucent. And then we have to think if there's something happened there. It's not just to give a diagnosis, exact diagnosis, that is malignancy, a lymphoma, or that is the something other malignancies. But you have bear in mind that there may be not just periodontal diseases. There are other diseases also can invasive in the bone, can give this, for example, lymphoma, for example, Langerhans, histiocytosis, also can make the lamina due destroyed. So that is the case. So we have to make more carefully observation. If we can see these changes in bone patterns, and then we can refer the patient to make more examinations. For example, to make a CT examination or CBC examination to see if there is bone changes and bone lesions there, and that will help us to make more further treatment to the patient. Otherwise, we neglect this lesion, just tell the patient that this is the periodontal lesions, that is the periodontal diseases, and then maybe will be postpone the treatment of the patient and also delay the correct diagnosis of patient. So I think what I want to tell you there is you have to be carefully analyze every part of the image, every anatomical structures, and then to see if there are some changes. Also, you have to know that the malignant addition is very rare compared to the cyst, compared to the benign tumors. So this is also the rarely thing.
Okay, thank you, Professor, for the question. Maybe inform the chat is not. Audience, maybe we still have time for the question. Maybe you have another question for Professor Gangli. Until we wait, Professor, maybe I want to ask something for you. I have a question. You say that your presentation that we have to different about where is the lesion form. Maybe there's a form soft tissue or the form in hard tissue. How to different is it lesion from the hard tissue and the soft tissue? Like as in OBG maybe we must separate in the maybe the case is squamous cell carcinoma. We can how to different that this is the squamous cell carcinoma from the soft tissue or inside the bone. No, Professor, it's no sound.
Sorry?
Yeah, thank you.
It's okay now. Yeah.
Okay.
If we only use the panoramic radiographs, I think it's very hard for us to differentiate the lesions within the soft tissues or also within the bone tissues. But if we look at carefully, I think if the lesions arise from the soft tissues, maybe the destruction in the bone is very less. And also you can see the complete border or inferior border, or there's maybe some bone destructions within the bone tissues. But if that is originally from the bone, and the lesions maybe can get more destructive to the bone tissues. But I prefer if you have such questions, I prefer to have CT examinations. And if you don't have a CT, I think CBCT is also okay for the first step to see if that is the real lesions from the bone or real lesion from the soft tissues.
Okay, thank you, Professor, for the question. Panitia, ini ada kiriman foto dari Dian, Dr. Dian. Bisa di-share nggak? Oh, maybe Dr. Dian. Dr. Dian, you can ask directly to Professor Gang. Dr. Dian, maybe Dr. Dian for Maranatha University. You can ask directly to Professor Gangri. Maybe he have
Dokter mungkin boleh kalau mau di-share gambarnya, Dok. Nanti kita bantu share screen.
Iya. Dr. Dian, bisa di chat aja Dr. Dian. Maybe we wait some for Dr. Dian. Maybe Professor Gang, I have another question for you. Continue about the CBCT. Maybe I want to ask about the CBCT and CT. Is it possible for us? We don't have CT in our university, in our hospital. We don't have CT. So is it possible for us to look the soft tissue in CBCT? Because we don't have CT, Professor. How to maybe you have
yes, it's a very difficult question because that depends on what CT machine you used. For some CBCT machines, you can see the large muscles in the CBCT images. So you can recognize, for example, master muscles there, but for loss of the detailed small soft tissue, we cannot recognize from CBCT images. If there is something, sometimes if you make it very, very bright, and then maybe you can see some outline of soft tissue, like mandibular salivary gland there, or maybe master muscles, or lateral muscles, or like this. But most of machine, you cannot recognize these soft tissues.
Thank you for the answer, Professor. Maybe we have Isti in here. Isti, do you have any question for the Professor Gan or the other audience? We have a question, another question from University of Indonesia. Dear Prof. Gangri, I have one more question. How do we differentiate osteomeritis in lytic stage which has periosteal reaction with the malignant, which also has periodontal reaction. Maybe like that, Professor.
Yeah. I think most of malignant lesions has no reaction to the periosteal reaction because if that is the lesions origin from osteo, like osteosarcoma, something like that, ostate, the periosteal reaction is totally different from the one that the osteomeritis gave us. So the bone reaction to give the new layers of the bone is not the same as the malignant one. So usually if the lesion is from the squamous carcinoma, cell carcinomas, and then usually it just shows us the bone destruction. There's no the periosteal reaction. So that makes us to differentiate from inflammatory lesions. And if sometimes in rare case, if the malignancies combined with the inflammation, and then may give some periosteal reaction. So in that case, I think it's sometimes difficult, but you have to think more other signs if you can get from the clinical examinations. For example, if there is some numbness from the lips or tongue, so that may be some signs, but sometimes it's very difficult for this kind of lesions. But most of the time, for most of cases, the malignancy is different from inflammatory lesions.
Okay, thank you, Professor, for the answer. This is the next question from Dr. Johannes. Dear Professor Gangli, is it very nice to have a presentation for you? Professor Gangli, I would like to ask you a question. When you use CT to examine a benign or malignant tumor, did you see contrast resolution or without contrast? Thank you, Professor, and have a nice day. Did you
use CT to examine benign or malignant tumors?
Yeah.
What contrast resolution? Okay, maybe if you use the contrast medium, yes, I think we must use it. Sometimes because you cannot differentiate from benign to malignant. So what we can do it is to make the contrast enhancement to the images to inject some contrast medium into the body, so that if that is the malignant lesions, because the malignant lesions usually have a very rich vessels to get more neurons. So that means they have much more, they will be enhanced, after injection of the contrast medium. So this will make the differentiate between the benign and malignancy. Just as the case 3 I showed you, in that case, we also use the contrast medium in order to differentiate from the malignant and benign conditions. Because after we have injected the contrast medium from the images, you can see that the inside of the image is still radiolucency. There's nothing enhanced on it, but the border a little bit enhanced. So that indicates that this lesion is the benign lesion, not the malignant lesions. So that is why we have to use the contrast medium for the differentiation between malignancy and the benign tumors.
Okay, very nice, Professor. This is maybe we wait for the next question. There's this is from Dian maybe. This is from Dian. She shared the radiograph This is complement is the left mass in here, but she asks where is the focus of the lesion? Maybe like that, Professor.
Yes, I see it. I think it's in this part, and in the left mandible, just beneath the root tips, the first premolar molars, right? And this part. And if you compare with the lateral part, the control part, the right part, you can see there is a radiolucency. There is a radiolucency this part. But the inferior border is complete. And you have to see, you can clearly see this, the mental flamen. But you cannot see here. I think I suggest you to make a CBT examination about these lesions. So that's the lymph node normal, cerebral gland normal, no mice, no flat. So I recommend you to make a CBT examination. I think there's some lesions here, but not sure what is that. Is that you have to think more, I think. You cannot see from the images, you cannot see the normal pattern of the trabecular bone. It seems that's a Lytic here. Or we cannot share. That is just beneath the roots of the premolars and molars. If you use a mental flamen, you can see there, but you cannot see from the other part of the. So I recommend you to make a CBT examination to see if there are some changes there. But sometimes you have to know that there is the fossa, mandibular gland fossa here. Is sometimes this can give a shadow or a lower density in this part of the mandible. But you have to see it in both sides. Also, you see it gives the same appearance in the other side of the mandible. So if we look at the right side of the mandible, we can see this is part is the trabecular pattern is good, pattern is good. But here we cannot see exactly the patterns. Trabecular bone maybe is destroyed. Also, this part is distorted. The anterior part is distorted. So I recommend to make a CBT examination or CT examination on it.
Thank you, Professor. Maybe Dr. Jan, we must the city. Maybe that's maybe we must take the city first before we get the diagnosis like that. Maybe, Professor. This the next question. Maybe the last question for Dr. Mani. Panitia bisa di itu. Oh.
Hi, Dr. Professor Gangli, how are you?
Oh yeah. Very nice meeting you, Manny. Yeah.
Hi. Nice to see you again.
Yeah.
I have one question actually. I sent the case to Dr. Lusi.
Yeah.
If you don't mind, would you please share? This is the case of slight swelling in the corner the mandible, right mandible, and the angle of the mandible. No pain, slight swelling, and very slow growing. And if you can share the case with Lusi.
Sebentar dok, lagi di download dulu.
So it's a big because it's from the PDF, from the construction from the CBCD is a big size of the file. Maybe it will took more time to download. And there's a mass, the expansion of the mass to the in the right angle of the mandible, and I saw that the mass is well defined, the border well fine, but the internal structure is mixed, have hypo and hyperdense, clear. And the masses expand and displace the third molar to the ramus. Wait, sorry, let me already download.
Yeah, yes, already download. But the committee prepare for this. Wait for the second.
Yes, but for your description, I think first impression is that it's the benign things.
Yeah, first impression is benign, and yes, this is the. Thank you, Dr. Lucy. Can you scroll down? Scroll down. I think it's better. Yes. Yes, yes. More down. This is the maxillary area. Next page. Yes, that's, yeah, okay. It's from the axial view, you can see the right side. Yeah, there's a bone formation actually, but from the sagittal view, this scroll down. Yes, so it's stopped. Yes, it's enough. Yeah. So this is, I think this more clear to see the lesion. So what do you think about this case? The patient is 23 years old lady. There's no pain, only a slight numb. So
yeah, that is there is some paraosteo reaction.
Yes, and the displacement of the mandibular canal is also slightly downward. Yeah, and I'm wondering, there's it is malignancy, tend to be malignancy or a dysplasia of the bone, like fibrous dysplasia sometimes has this kind of feature. I'm still, from my point of view, this is the dysplasia of the bone. Is it? What do you think about this? What is your opinion?
Yeah, from the images here, my experience, my expression about these cases is benign things, not malignant things. And have you seen this is the second molar, that is the 4-7 is impacted.
Yes.
I've noticed that, and also there, there is impacted, and also the 4-8, and also you can see that there's capsule here is around him. Maybe there's some reaction from these inflammatory lesions because of the impacted tooth. I think that is the most possible reason to give this bone paraosteo reaction here. And also we can see there is some thickness, that density around the third molar, around the second molar, and around this. Also,
yes,
I think the canal is in its place. So I think most probably from the inflammatory lesion. There is here there is a infection here. So maybe this inflammatory lesion and then gives the reaction from the paraosteo bone. Maybe that is the reason. There's no lymph nodes enlargement. What about the lymph node?
Only slight. there's no swelling, slight
There are some-
swelling.
Okay,
Only
is there
slight
some
swelling.
pain? Is there some pain? If you cover it?
Yeah, only slight. Actually, the chief complaint is only impacted teeth, impacted molar. So it's incidental finding, I think, because there's no major complaint of pain or swelling.
So this is a 32 years old man, right?
23 years old girl.
20, okay, a girl that's 23 years
Yeah.
old.
Yes.
So, okay. So have you suggested her to make some treatment for the 4-7?
Not yet. There's the 4-7 is also intruded and also impacted.
Yeah, I think maybe you can use treatment diagnosis for these diseases to just move the reasons to see what happened. I think it's most probably from these teeth, from this tooth. And
From the
just
the
4-7.
Okay.
Also, you can
Dr.
see
Lusi?
there is
Can you
small
move?
radiopaque stalls in the distal part of the 4-7. So that is very small. I don't know if that is the bone fossa, that is the dice bone, part dice bone. So see, please go down. Here, we can see the destruction. Maybe you can see some destruction of the bone here. Yeah.
Okay. Yeah.
Most probably, I think most probably from this lesion. So if you move the teeth and give some antibiotic treatment to see what happens, most of cases it will becomes normal. The bone will become normal again.
Yeah, but I don't have any information about this patient because I asked the doctor who referred this patient to me, and this patient hasn't come to the doctor to follow up the case. So I don't know what is the treatment for the follow-up treatment. Dr. Lusi, can you scroll up for the axial? Yes. And can you zoom in? Yes. So there's a cortical discontinuity destruction in the lingual side. Yeah.
Yeah, I see. Yeah, but that is seems that is new bone from here. That is the destruction, not the bone. Yeah, I can see here is the destruction here. Is that connected to the lower border of the periosteal reaction or periosteal bone, newly formed bone?
Yes.
Is also this related to the tooth? 7, you can see here is the 7. 1, 3, 4, 5, 6. Yes, that is 7. The 7 that is the distal part. Yeah, that is distal part. You can see is the lesion here that is connected together. That is the part. Yeah. So there's no nerve numbness. There's no, so nothing different from normal, right? The nerve sense normal. Yes. So I would like to recommend that is first to think of the infection from the tooth. And
how about the displacement of the tooth for 8? So the tooth for 8 is
I don't think that is I don't think that is the displacement. Maybe that is only the place. Let's go down to look at let's go down, look at
the sagittal view, Dr. Lusi.
Yeah, please go down.
Okay, the sagittal view. Yes. Yeah, I think.
Yes, yes, maybe that is in the place. I don't think it's a displacement of the.
Oh, okay.
To say.
So this is more likely the inflammation reaction.
Maybe
Yeah.
the osteomeritis, maybe, Prof. Yeah.
Okay, but I wonder that there's no pain, there's no inflammation sign of this patient, no redness. Everything is seems to be
there is
normal.
another possibility. Yeah, there is another possibility. It is I don't know if it is, but you have to think of it to be the differentiated diagnosis. That is the histocytosis, Langhans histocytosis, Langhans cell cytohistosis. They sometimes give just in young girls, in young persons, and give such kind of appearance about it. So you have to think of this also. If you have no others evidence to support your inflammation diagnosis, you have to think in Langhans cell histocytosis.
Okay. And how about the dysplasia of the bone, like fibrous dysplasia? Do you think is it possible to differentiate with this kind of lesion?
I think it's the appearance of the bone, also the action, more like perosteal reaction rather than the appearance from fibrous dysplasia. More like more like the reaction to the inflammation.
Okay.
So you can also think of it, but I don't think it's important.
Okay. Okay, I think it's more clear for me now. Thank you very much, Professor Gandhi.
Thank you.
Thank you, Professor Gandhi.
Thank you, Dr.
Very,
Lusi.
very nice cases. Thank you, Manik. Very nice.
Thank you, Dr. Butik.
Thank you very much,
Thank you,
Dr.
Professor.
Lusi.
Thank you, Professor, we have just one question. Is it possible? We have one question, another question, just one question. Is possible for you? It's okay?
What I cannot see the picture. I think he also uploaded one. Okay.
Oh, yes. Nisa. This is another case from Dr. Dominika Diat. Where is the Yes, this is the question. How to suspect this lesion in CBCT? She asks about the correlated with the impacted tree. Impacted tip on 23.
Yeah. Yes. From the panoramic images, we can see that this one here, you can see that is the 2-2 is impacted. And also around him, there is a cyst-like lesions there. And also here, you can see a radiopaque mass also here. And 2-3 is displaced laterally. You can see displaced distally. And here is the 2-2, and there's mice here, and also there's the cyst-like, and also I don't know if this is odontoma or something. Or here is the cyst. Let's go to the next the CBCT image. Let's see what exactly. Yeah.
There's no odontoma.
yeah, there's something here. And then you can see, but usually, if that is the odontoma, it should be beneath of the impacted teeth in the upper jaw. Can you show me the next page? Next slide.
It's the last.
Here's the last one. Oh, that is show
one.
the canine. That is the canine, and that is the place the things. Oh yeah, here.
Maybe it's like dentigerous teeth. Maybe the professor.
Yeah, you can see a cyst here, and
Mhm.
also you can see some mice here. The mice looks like you still see the dotty there, but I don't know. If you ask a question, the patient, if they have made some bone implanted in the maxilla or nothing do.
Yeah.
What do you think of the mice here? Is that, have you asked the patient about here is make some implant, bone implant inside the bone or nothing done before?
In maxilla, Professor.
Yeah, in maxilla,
Yeah.
in the place. And how old of the patient?
How old, Dr. Dian?
Yeah, the patient. I think it's young.
Dr. Dian, how old is the patient?
Yeah.
Around 25.
Oh yeah.
It's younger.
Yeah, it's younger. So that is got impacted. So have she or he made some bone implantation? Nothing do before come to you, right? So a person that is the sister lesions there, and the difficult part is from the mice just above the 2-2. So that is the maybe we have to think is if we thought that mice there, maybe a tooth cyst will be give a diagnosis. But if we consider of that mice, we have to think more. But at least that is maybe that is you can think of the there's some little pigs. If we think in this way, that is the little pigs inside of the cyst and just close to the 2-2, and then maybe we can narrow diagnosis and to think of if that is the calcifying epithelial odontoma tumor. That is also one possibility because there's mice there, so you have to think it also calcifying cystic odontogenic tumor. So if there's no such mice there, it's just a cyst. But if you have mice there, you have to think more. So at least you can give a diagnosis of benign tumors or benign mice in the anterior part of the maxilla. Differential diagnosis should be calcifying epithelial odontoma or epithelial odontogenic tumor.
Okay. Maybe Dr. Dian, is it enough? And this enough, maybe, Professor. Is time is thank you very much, Professor, from Dr. Dian. Maybe this time for we to appreciate for Professor Gangli. Professor, thank you very much for your knowledge and for your information, for your lecture for us. It's very grateful to have a new knowledge from you, Professor. This is maybe the end of this meeting. Thank you so much for the audience. Thank you. I back to Putri.
Thank you very much, Dr.
Thank you.
Lucy. Thank you
Thanks
very
so
much,
much.
Professor
Thank
Lee.
you all.
Yes, thank you very much for the enlightening presentation about the basic principles of image presentation. It's such an interesting presentation, Professor, since sometimes we found so many radiograph appearance to consider in differentiating the benign lesion from the malignancies. I wish there will be another lecture session in the future, Professor, or maybe we could make some another collaboration in research, Professor.
Okay, thank
Now,
you. Thanks so much.
thank
Nice
you.
meeting you here. Thank you. So
now, before we wrap our session up today, there will be certificate submission to our speaker, to Professor Lee, and to Dr. Lusi that will be given by the Vice Dean on behalf of the Dean of Faculty of Dentistry, Universitas Padjadjaran, Dr. Sri Susilawati, Magister Public Health, Ph.D.
okay, thanks.
Yeah. Thank you very much for amazing lectures, very nice and inspiring presentation, Prof. Gangli. Panitia, apakah untuk Prof. Gangli dulu atau untuk Dr. Lusi dulu? Ya, Prof. Gangli, this certificate of appreciation is presented to Professor Gangli for sharing valuable knowledge as visiting lecture speaker today. All thanks to your enlightening case that inspires so many people out there. Thank you for making time to sit through this visiting lecture. I look forward to our next interaction soon. Thank you so much, Prof. Gangli.
Thanks. Nice to talk with you. Thanks.
And for moderator, yeah, Dr. Lucy, thank you very much. And also this is to certify our moderator, Dr. Lusi Epsilawati M.Kes, Specialist Radiologi Kedokteran Gigi Konsultan, for guiding our discussion panel. Thanks for capturing the audience so well. It was lively, engaging, educative, and fulfilling because of your presence. Wishing you all the best for your future endeavors. Thank you, Dr. Lucy.
Thank you so much, Dr. Susi.
Thank you, MC. Yeah.
Thank you very much, Dr. Susi, and for all the participants and also Professor Lee. We now move to the photo session, Professor. Maybe we can take a picture together. So to the participants, please turn off and open your camera. Okay, the screen capture would begin in 1, 2, 3.
Putri, dimut Putri.
I'm sorry, Doc. Thank you very much, Professor. Thank you, Dr. Lucy. Thank you for all the participants, for all the committee. This is a very super enlightening lecture, I think. Thank you. I think this is the final session. I hope you are safe and healthy.
Thank you. Hope you are all healthy and safe.
Yeah,
thanks.
Thank you, Professor Gangli. See you next time.
Thank you. Thank you.
Thank you.
Terima kasih kepada semua partisipan. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Suharjo, sehat-sehat ya Prof. Terima kasih Prof. Suharjo, ya Dr. Lucy dan semuanya.
Terima kasih banyak.
Ya Dr. Ashari, terima kasih pamit semuanya.
Terima kasih. Sama-sama dokter, terima kasih. Terima kasih buat semuanya. Terima kasih.
Terima kasih, Dok. Terima kasih, Dokter Meni.
semuanya, Dr. Lusi juga.
Terima kasih Dr. Prof. Semuanya
Terima
sehat-sehat semua, Prof. Dok.
Semuanya.
Terima kasih dok.
kasih ya.
Iya dokter, terima kasih.
Bye bye.
Sampai dokter.